Shoulder dystocia drill is a structured team-based simulation to practice rapid recognition and systematic management of shoulder dystocia in vaginal births. It focuses on effective communication, correct maneuver sequence, and minimizing maternal and neonatal morbidity. Let us watch a shoulder dystocia drill recorded in a secondary level center.
The head delivered, but it doesn't rotate. See, there is tentacular sign appears. I suspect shoulder dystocia. Call for help. Please call gynecologist, also anesthesiologist, pediatrician and nursing supervisor. See, your baby's head came out, but there is some difficulty to deliver the baby's shoulder. Don't push, don't push. Agila, please start shoulder dystocia protocol. We face some difficulty to deliver the shoulder. Be calm. Our full team is on the way to help you. We know what to do. Please don't push. Krishna, please start timekeeping and document all steps. Now let me evaluate the episiotomy. I am going to extend the episiotomy to facilitate the maneuvers. We are adjusting your position to help your baby's shoulder come through.
Flex the mother's legs tightly onto her abdomen so that the epidiameter of the inlet will increase and anterior shoulder will sweep through. And this is McRoberts maneuver.
Still, the anterior shoulder is not coming out. And so, we have to enter the other maneuvers. Agila, please give suprapubic pressure.
Give suprapubic pressure with heel of the palms, one over the other, above the pubic symphysis, over the posterior aspect of the anterior shoulder of the baby, so that the baby's shoulder will flex and the bisacromial diameter will decrease, and so the anterior shoulder will come out. Give suprapubic pressure for 25 to 30 seconds. So episiotomy extended, McRoberts maneuver done, suprapubic pressure given, still the head is not coming. Please give suprapubic pressure in infralateral direction. And now we can enter Rubin's 2 maneuver. Introduce your index and middle finger at 7 o'clock position and swipe towards the anterior shoulder, posterior surface of the anterior shoulder, and flex the shoulder anteriorly so that the bisacromial diameter will decrease and baby will come out. Rubin's 2 maneuver is also failed. Now we can introduce Wood's corkscrew maneuver. Here the fetus is facing the mother's left thigh. So one should introduce the right hand at the posterior part of the vaginal canal and the left hand at the anterior part of the vaginal canal to facilitate the rotation of the fetus. It is recommended to utilize the index and middle fingers of both hands during this maneuver, referred to as the corkscrew maneuver. If this technique proves ineffective, an alternative approach involves reversing the position of the hands to perform a reverse Wood's corkscrew maneuver. Still the baby is not delivered, and now I am trying to deliver the posterior arm. Introduce your right hand posterior to the posterior arm of the fetus, aiming to reach the elbow of that arm. Once you have located the elbow, flex it and gently guide the fetal hand along the chest wall to facilitate the delivery of the posterior arm. Now the baby is delivered, hand it over to pediatrician. The next step is to perform active management of third stage of labor, then delivery of the placenta, cervical and vaginal examination to rule out potential trauma that could lead to postpartum hemorrhage, and closely monitoring the patient for signs of atonic PPH. Please give me cervical inspection set. Cervix and vagina examined, no tears and no atonic PPH also. Your baby's shoulders become stuck. This is called shoulder dystocia. It is an unpredictable emergency, but we used recognized maneuvers to help deliver your baby safely. Your baby will be checked for any nerve injury. Most recover fully if affected. You have a slightly increased chance of this recurring in future pregnancies, around 10%, and we will document everything and discuss a plan for future births. And now, Krishna, please read the documentation part loudly.
Laya, 23 years, primary gravida, 39 weeks, 6 days, had spontaneous vaginal delivery, birth weight 3.9 kg, no history of diabetes, diagnosis and time event time 2:01 pm, head delivered at 2:01 pm, shoulder dystocia recognized after 90 seconds, 202 30 seconds, help called, senior obstetrician, anesthetist, pediatrician, SNO, manuals used in sequence, manuals done and time. 202 30 seconds, call for help, episiotomy evaluated after 30 seconds, 203 pm, Roberts manual, 203 15 seconds, suprapubic pressure given for 30 seconds, internal manuals, 203 45 seconds, Rubin 2, 204 pm, wood screw, 204 15 seconds, reverse wood screw, 204 30 seconds, delivery of posterior arm, 205 pm, baby delivered. All four Gaskin's position and other manuals not done, fundal pressure not used, head to body delivery took 4 minutes. Personnel present, lead accoucher, Sarita, nursing officer, senior obstetrician, Dr. Reena Enna, duty gynecologist, Dr. Rajesh, anesthetist, Dr. Sharan, SNO, Minimol, neonatologist, Dr. Roy, nursing officers, Akhila Krishnapriya. Maternal outcome, perineal trauma, only episiotomy. There was no postpartum hemorrhage, estimated blood loss 500 ml, no other complications. Neonatal outcome, male baby 3.9 kg, Apgar scores 7 at 1 minute, 9 at 5 minutes. Head to body, delivery interval 4 minutes. No newborn resuscitation required, no Erb's palsy, clavicle fracture or humerus fracture. NICU admission not required. Communication and debrief. Parents informed of the events. Explanation of manuals and outcome. Neonatal examination explained. Opportunity for questions given. Follow-up and reporting. Incident form completed. Shoulder dystocia performa completed. Neonatal follow-up arranged. Maternal follow-up arranged. Signatures of all personnel participated.
That was a stressful scenario. How is everyone feeling?
We tackled it successfully, ma'am.
Yes, correct, Sarita. You really need appreciation. Early detection of shoulder dystocia, clear verbalization, and prompt call for help. Good teamwork and calm communication. And prompt execution of first line manuals. And now, anything to improve?
Medical inspection should be ready, and there should not be any delay in getting these instruments.
Cervical inspection set and all other instruments should be ready, and there should not be any delay in supplying this in getting these instruments. Coming to technical side, Macrobots manual done promptly, suprapubic pressure given in correct direction, internal manuals attempted in the right way, and posterior arm delivered promptly. And now listen for neonatologist opinion.
See that the baby is in universal flexion position. That will rule out any fracture clavicle, brachial plexus injury or hypoxia of the baby, and it will ensure that the baby is well.
And coming to maternal side, no PPH, no third or fourth degree tears, and mother was briefed in time.
Good leadership by Sarita, good teamwork by doctors, Reena Madam, Roy Sir, Rajesh Sir, and proper and meticulous documentation by Krishna Priya.
And key take home messages are: early call for help saves time, macrobots and suprapubic pressure first, posterior arm delivery is highly effective. You managed a high risk obstetric emergency safely. These skills saves life, and thank you so much.